our international speakers. Um, we are very pleased and very honored to have with us today 4 international speakers who have taken out of the time to be with us, to share with us their vast experience and their great knowledge. Professor, let me say first that this is our committee in Egypt, consisting of 4 fellows and 4 members, Professor Ghiyas al-Bishri, Abdelghis Sarhan, Ahmed Zakaria, Hassan Abu al-Makarim, and Dr. Wafa Benjamin, who is with us today, Dr. Ahmed Mustafa, Miriam Hanawani, and Samih Salama, and in collaboration, of course, with the Egypt UK Liaison Committee, who are a group of Friends of Egypt consultants in the UK, headed by Professor Muhammad Abdel Fattah, who is a professor in Aberdeen. Now, our first international speaker is Dr. Sonia Malik. Dr. Sonia is a very important figure in the field of assisted production in India, in her part of the world, and in the world, in fact. She is a senior consultant in obstetrics, gynecology, and reproductive medicine, and the director and head of the Department of South End Fertility and IVF Center in New Delhi, in India. She's the immediate past chair and infertility of the Infertility Committee of FOGSI, the Federation of Obstetrics and Gynecology Societies of India, and the immediate past president of the Indian Fertility Society. Dr. Sonia is going to talk to us about the emerging role of LH in assisted reproduction. I would like also to thank and welcome Dr. Tamer Nafa from Manchester. He is a consultant in fertility and assisted reproduction at Create Fertility Center in Manchester, UK. This is a very important IVF center headed by Professor Stuart Campbell, if you know Professor Campbell, of course, and Professor Geeta Nargund. He is in charge of the center in Manchester. Previously he was working for the academic unit of reproductive and developmental medicine and the University of Sheffield, where he received his second PhD. As we know, he has 2 PhDs actually, one from our university in Alexandria and one from Sheffield University. And he's formerly was a clinical lecturer in our department of obstetric gynecology in Alexandria University. Dr. Nafa is going to talk to us about recurrent implantation failure and update. I would also like to welcome and say that we are very honored to have our great friend and colleague, Professor Timur Gurgan, who is professor in obstetrics and gynecology at Hacettepe University in Ankara in Turkey. More importantly, he is the current president of the Turkish Society of Reproductive Medicine, but is also the past president of the International Society of IVF, ICSI, and the past president of the Mediterranean Society for Reproductive Medicine, and many other things. And today is going to talk to us about hysteroscopy, hysteroscopic endometrial injury for the treatment of repeated implantation failure, fact or vision. Professor Timur Gurgan, of course, has behind him the first IVF in Turkey. And from Canada, I would like to welcome Professor Elias Dahdouf, who is going to join us shortly because he's kind of busy just now. He's the founder and medical director of the Assisted Production Center in the Centre Hospitalier Universitaire de Saint-Justine, CHU, and the assistant professor in the Department of Obstetric Gynecology at the University of Montreal in Canada. He is very well known in our field for his work on genetic testing for aneuploidy, PGT, and PGS, as we call it now, PGTA, and he's going to talk us about the update on implantation genetic testing for aneuploidy. I would also like to welcome my friend and colleague, our dear colleague, Dr. Wafa Benjamin from Cairo. Dr. Benjamin is consultant of obstetrics and gynecology at the Mataria Teaching Hospital, one of the leading hospitals in Cairo in Egypt. She's the director of the reproductive health care unit at the Mataria Teaching Hospital. He's also a member of the scientific committee of the Egyptian Fellowship, the equivalent to ERC-RCOG in Egypt. And also, more importantly, she is our colleague and a member of the Egyptian Representative Committee of the Royal College in Egypt. I would like also to thank Merck Pharmaceutical for hosting us and for sponsoring this webinar. We would like and other activities of our committee. We'd like to thank them very much, Dr. Marian and all the colleagues. and would like to ask you to post your questions on the Q&A section of the webinar, not on the chat section, please. And I would like to apologize for Professor Michel Abu Abdallah. Professor Abu Abdallah, unfortunately, could not join us today. He is a little bit ill, and he cannot join us today, but he has asked me to send you all his regards and invite you to the Middle East Fertility Society meeting, which is going to be on the 1st and the 5th of December. It will be a virtual Congress, and my understanding is that there are some concessions for the young doctors and the residents. With this, I hand my microphone and my video to my colleague, Dr. Wafa Benjamin, to introduce or I will introduce Dr. Sonia Malik, and also Dr. Wafa will introduce the following speakers. And as I said, Dr. Malik is a senior consultant in assisted production in New Delhi, and she's going to talk to us about the emerging role of LH in assisted reproduction. Please, Sonia, the floor is yours.
Thank you very much, Professor Hassan. Thank you very much to the society for giving me this honor of being here with you all today. And let me just start with my screen. Oh God. Yeah. So well, many salams and masal khair to all of you here who have connected from Egypt, and to good evening and good morning to all the time zones that we are here. I bring you greetings from Delhi. Delhi consists of three parts. We have three types of cultures: the Mughal Delhi, the British Delhi, and New Delhi, as you can see over here. And from this past, a great heritage, we are progressing now to what is modern. And ART is a part of modern age. And therefore, today, we are collecting here to discuss what is happening, the recent advancements and developments in the field of ART. I thank you once again for having me here with you all. So I shall be speaking on the emerging role of LH in ART, as has been told to all of you. Let us just go through it and recapitulate as to what we should be talking about, or what we think should be in this lecture. What did we know and what is new? What are the sources of LH and are they different? Who will need LH and when? And is excess of LH detrimental? And then finally, we conclude as to what we should be doing. So when ovulation first was introduced by Kistner in 1958, it has since then become the standard treatment for all ovulatory defects. And if you trace the history of LH, we know that in 1931, it was first acknowledged, and then actually it was brought to the fore by Steen Lewenthal when they published their paper on elevated LH and anovulation. And then in 1959, we started talking about the two-cell, two-gonadotrophin theory. It was in early 1972 that Bernard demonstrated that small amounts of LH are definitely needed for a successful induction of ovulation in patients, especially having hypogonadotrophic hypogonadism. But then it was with the advent of recombinant FSH that it was finally realized that LH was truly essential for all patients undergoing ovulation induction. And if you just go through this cycle, we know that LH slowly rises up, and finally it culminates into a surge, which when ovulation happens and there is release of the egg, and finally it comes down, but it is still there in the luteal phase, wherein it is supporting the corpus luteum function and production of progesterone. So therefore, all through the cycle, it is LH which is actually producing some kind of activity. So when we look closely at the two-gonadotrophin two-cell theory, we know that initially in the theca cells, there are the LH receptors, and therefore it is only, it is helping us for the production of the androgens, whereas later on, in the later part of the follicular phase, when the granulosa cells acquire the LH receptors, then LH starts to have its action on the granulosa cell, and then it helps the FSH, it sensitizes the FSH receptors also to produce more of estrogen, and therefore it is helpful in the production of both the androgens as well as the estrogen. So LH plays a great role in the steroid biosynthesis. So if we just recapitulate and understand the role role in or LH in folliculogenesis. In the early follicular phase, it is the expression of FSH receptors only on the granulosa cells, which become responsive. They act and synergistically with IGF-1 and promote growth and increase. There is an increase in preantral and antral follicles which are recruited. In the intermediate follicular phase, on this other hand, like I said, it is on the granulosa cells, but it helps to sustain the FSH dependent granulosa activity and increases the aromatase induction. So finally, it is this role, which is the first part of what we are realizing now. And secondly, very importantly, at the time of maturation or final oocyte maturation, we know that during nuclear maturation and cytoplasmic maturation, LH plays a great role in both the extrusion of the polar body and the development of the metaphase to gamete over there. So the first part of oocyte growth is dependent upon FSH, while maturation is, and even the nuclear as well as the cytoplasmic maturation are all the functions of LH. And so at mid-cycle as well, LH plays a role. So this is the second part or important part that LH plays, oocyte maturity and competence. Thereby, it has been found that in the WHO type 1 women, which are absolutely lacking in LH, the oocytes have lesser maturity, have low fertilization rates, embryogenesis, blastocyst formation. For that matter, the oocytes are deficient in estrogen and they have a brittle zona. So therefore, they fracture very easily when ICSI is performed. So to just cut it short, the oocytes that are produced without LH in WHO type 1 women are actually not very good in both maturity as well as function. So LH therefore helps to form more competent and hardy embryos. And hence the third function, which is the luteal phase, as I said, it is to support the corpus luteum, production of progesterone, and finally the endometrial receptivity and implantation. So therefore, the luteinizing hormone is there right from the follicular phase to the mid-cycle surge, as well as the luteal phase. So the three major components or the three major functions of the luteinizing hormone are not so small. They are existing all through the cycle, all through the follicular, all through the entire menstrual cycle. Now, coming to what kind of drugs. So we know that over the years, we have evolved from the urinary products to the recombinant, and we have also evolved in the type of formulations that we have. But actually, we are looking at the LH component of these formulations, and we all know that there are urinary formulations in the form of HMGs, which are actually having LH-like activity. And then we have the recombinant LH, which is also present in the market now. So what is the difference? Actually, HCG and LH are very similar in structure, and hence HCG has been used as a surrogate for in ART in whatever we have been giving it. Majority of the times it has been used to help with the triggering of ovulation. So it has been used as a trigger. However, what is important is that the receptor, beta subunit of both LH and HCG, they bind to the same receptor. However, the final gene expression is different for both. It is more proliferative for the LH, whereas it is more pro-apoptotic for the HCG. That is primarily because HCG lives or stays inside the body for a longer time. It has a longer half-life, and this is actually has a very short life. So therefore, these two functions, even though they are acting on the same receptor, are different, and hence the production of different effects within the body. And that is why the usage of both is now a little different, as we are realizing as we go ahead with our induction ovulation in present times. So LH activity, as I said, is found in many of these products, HMGs, the purified FSH, which contains some LH activity of about 1 unit, but highly purified FSH contains very little. And however, we are more concerned with the recombinant HCG and the recombinant LH, and we know that there is a difference in the LH activity of both of them. And if you look at the content, the LH content of recombinant LH is much more, and it is comparable to a highly purified HMG. But if you are looking at recombinant HCG, there is no LH component in that. So where does all this information take us now? How is it going to help us when we are giving a supraphysiological stimulation to our patients and inducing a follicular development in our patients with different kinds of drugs and protocol? How is this new information or information about physiology of LH, which we have been knowing all these years, but have probably not looked at it as closely as we are doing now? So how is it helping us? So do we need to now understand is, do all our patients need LH supplementation during COS, or are there some who might benefit from this treatment? We know for sure that it is the hypogonadotrophic hypogonadal patient who is definitely going to need it, because they have a very low value of LH in their bodies. And for some patients, there may be some patients who are deficient in LH during stimulation and they would need it. But of course, majority of the women will be able to tackle stimulation with FSH only. And that is what the studies have been showing all these years. So again, on the other hand, one, of course, we are talking about the deficiency, and on the other hand is the phenomena of endogenous high LH as we find in the PCO patient. So are these high levels supposed to be responsible for the presence of multiple atretic follicles? And should this level be brought down in order to induce an efficient folliculogenesis, is something that is debatable. And of course, some people agree to bringing it down, whereas others say that it should not be done. And a Cochrane review of 2007 actually said that there is no benefit of supplementation to an unselected population, and it would benefit only when there is profound LH suppression in GnRH agonist protocols, or when the patient has a poor ovarian response, and when there is a potential benefit and out in patients who are of older age group. So if a woman is older in age, or she is showing a poor response maybe from the last cycle, or she has been very badly suppressed, such patients may be given LH supplementation. This was way back in 2007. This review was revised in 2017. However, the results are still controversial, and not very concrete evidence has come out of that review as well. So let us go further and see what exactly are we looking at and what are we trying to figure out. So it is said that LH has a therapeutic window, and there is a ceiling level as well as a therapeutic level. An optimal level is somewhere between this, a threshold level as well as a ceiling level. A threshold level is that of 1.2 or little above that, whereas a ceiling level should not be more than 5. So this is where we should be. If it is too low, there is impaired follicular growth. And if it is too high, then there is follicular atresia. So therefore, basically, we have to keep it somewhere in between. And it is now decided after the European recombinant study, LH study group met in 1998. They studied all this and they found that there was the optimal dose for LH is about 75 IU. And this window of LH, this concept of LH window was further potentiated by more studies somewhere in 2002 and 2008, where if it is below this, below 1.2, it was found to have an impaired follicular development. So if you can just concentrate and see, if we are looking at the two-cell gonadotrophin theory, then if it is a low threshold, then it is on the first compartment, the thecal compartment, where it affects, and therefore there is defective follicular development. However, if the ceiling is crossed, if it is above 5, then there is an LH receptor downregulation and there is suppression of the granulosa cell proliferation. So on the contrary, now it is the other part of the gonadotrophin cell, the second cell, which is more affected, and therefore there is follicular atresia. So both the levels are having their own kind of effect on the two cells within the ovary, and therefore the outcome in both the cases is going to be erratic. They therefore need a definite optimal level. What happens to the surge then? What is the effect on the surge, LH surge? Now, for an adequate LH surge, we need only 5% of LH, which is given to the body, just to induce the oocyte maturation. But in order to have ovulation to occur, if only ovulation has occurred, then you need 85% of the gonadotrophic surge. So basically, when we give a trigger of a higher dose, that means about 6,500 of recombinant, or about 5,000, or maybe even 10,000 of HCG in some cases, then in that case, 85% of this is required for ovulation, whereas only 5% is required for for the maturation of the oocyte. This is an important thing to understand. And with this kind of a knowledge then about the physiology of LH within the body, and within understanding that there is some kind of an optimal dose which is required, we have moved from ovulation in mere ovulation induction to now the individualized controlled ovarian stimulation, the ICOS as we call it. And initially, when we were doing ovulation induction, we were following the 1976 WHO classification, where we were looking at normal women and we were looking with ovulatory women with type 1 and type 2 dysfunction. And now what has happened is we are more bothered about the ovarian response rather than this kind of a classification, where we are looking at hyper responders and poor responders, we are looking at normal responders, and we are looking at hyper responders. So basically, the shift has been in the type of patient is remaining the same, but the shift is more on the outcome rather than this. And therefore, we have to understand the physiology in a much better fashion. So what is then the effect of the protocol on the LH? That is what we need to understand. LH may be naturally deficient because of the age, and it may be deficient because of hypogonadotrophic women, genetically, as you have in LH polymorphism, or it may be unknown. Or secondly, it may be deficient also because of an iatrogenic deficiency caused by GnRH analogs. So age, how does it affect LH deficiency and how does it cause it? Ovarian function is depressed at all ends, and there have been studies to prove that there is depressed androgen secretion, functional LH receptors are decreased, LH immunoreactivity is less, and ovarian paracrine activity also becomes less. So the mechanism is that the FSH is much more, it is increased because of a short follicular phase in many of them, and otherwise as well, sometimes there is a malfunction of the cells, granulosa cells. Therefore, there is, it stimulates the ovary to produce, or the granulosa cells to produce more progesterone, which has a detrimental effect on the endometrium, as you all know. And this has been found that if you supplement these patients with LH, then it stimulates this gene CVPF1 to convert progesterone to androgens, which can be further aromatized to estrogens. And hence it brings back the milieu within the granulosa cells to an estrogenic milieu, thereby correcting the whole thing. So therefore, when the patient is of an older age, above 35, it does make sense to give them a bit of LH when we are stimulating them. What about the hypo? These patients, as we all know, are deficient in LH, and the ideal protocol is something which uses both FSH and LH. In the absence of LH, the follicle size will increase, obviously, but the estrogen levels will still be low, and this will give rise to a good number of good quality oocytes, but there will be a poor implantation and an increased miscarriage rate. So however, therefore, if you're using a recombinant FSH, it is mandatory to use some amount of recombinant LH as well. And the other option is, of course, to use HMG. What about the normo and the hyper responders, or the WHO type 2 women, as we used to call them, or we are still calling them? LH would only be required if the levels are very low due to downregulation. And it was found that levels below 1 are equivalent, or quantification even at 75 IU, but follicular genesis, pregnancy rates, and everything was normal. However, therefore, it was decided that if the LH levels are below 1, then supplementation would be required. In the antagonist protocol, however, such levels can be seen on day 6 of stimulation, thereby suggesting that complete downregulation takes some time even in the antagonist protocol. Therefore, the LH supplementation could be started a little later. So if you look at the various studies that have taken, that have been performed, some of the studies where severe downregulation of the GnRH agonist has caused LH deficiency, then you find that it has had an effect on the fertilization, on early pregnancy loss, on the live birth rate, cryopreservation, and all the factors, therefore, even the amount of FSH used and the implantation rate and pregnancy rate, all of these have been affected if the patient is severely downregulated. Then the other extreme, the patients who are now, according to the Poseidon stratification, as we are all using now, they are either poor or hyper responders in these four groups, as you all know. And out of these, the first two groups are more important for us because we can really do something for them. The third and fourth, especially the fourth group, is actually something where we can hardly do anything much for them. But however, in these patients, again, what has been found is that there is a definite benefit by supplementing them with LH. And if you look at this paper of 2011, where there have been some recommendation to guide the use of recombinant LH in assisted reproduction, this paper is especially for the Asian populations. And here, if you look at the indications for use, it is either a prior poor response or an ongoing suboptimal response, or patients at risk for suboptimal response. And who are they? Aged more than 35 and a day 6 LH of less than 0.5. So basically, these patients have been given LH and they have found a better outcome. Similarly, the recommendation has also been that if there is substantial evidence of benefit of RLH in addition to FSH in these kind of patients who are responders, defined count which is less, and mid-cycle suboptimal response or no follicles, some evidence of benefit of LH in addition to FSH if the patient is more than 35, like I said, and these are the studies for that. There is still some research required for the biomarkers of variants, but we all know that now we have more studies to prove that even the LH polymorphism can be overcome to a certain extent by increasing the dose of LH in such women. So the rationale for LH supplementation is if a patient has poor oocyte quality, reduced fertilization rate, reduced embryo quality, and increased miscarriage rate from a previous cycle. So in such cases, we need to supplement them. And therefore, we all know that the indications now are increased age and poor response. So who is going to reach LH? Normal women with normal gonadotrophic women undergoing stimulation where the LH is reduced due to our protocols, or patients who are inherently low, such as women more than age 35, poor responders and hyper responders. So that brings us to so now the last is that this is a recent review from 2018, which suggests that, okay, here we need to give it to hyper responders, advanced age, co-treatment with GnRH antagonist also in addition to agonist, and profoundly suppressed LH levels after GnRH agonist, and to a certain extent also to prevent OHSS and poor responders. Now, when we look at the mid-cycle use of LH, instead of, or the function of LH instead of the follicular genesis, in addition to the follicular genesis, I would say, we all know that HCG administration has been the gold standard for final follicular maturation. However, we also know now that we have three kinds of triggers that we are using in clinical practice, that is HCG, GnRH agonist, and dual trigger. And how do they function differently is what we need to understand. We know that the natural surge is like a parabola. It rises 14 hours, stays like at plateaus for 14 hours and falls down for another 20 hours. Whereas the surge which is produced by HCG is slightly longer, it lasts longer. However, it finishes by day 8 of the cycle, and the GnRH agonist trigger is very, very sharp. The surge is very sharp. It falls and rises and falls within 20 hours. There is no plateauing. So there is a difference in the surge. And what effect does this have? It actually has an causes an abnormal luteal phase in these patients where it is used. In the HCG triggered patients, the latter half of the luteal phase after the 8th day is deficient in LH activity. And in the GnRH agonist, which has a very short role, the LH activity deficiency period is larger. So luteal phase deficiency is found in most of these cycles, lesser in the HCG triggered cycle and more in the GnRH agonist cycle. And this has a bearing on what we are going to understand. So the difference is that HCG stimulates only LH, whereas GnRH agonist stimulates both LH and FSH. It is more physiological, but it is very sharp. and there is a luteal deficiency over there. OHSS on the contrary is rare. However, here it stimulates, it acts on the LH receptors. The half-life is longer, and therefore the action also lasts longer, like I mentioned earlier. Is also the luteal support is definitely better, but yes, towards the end there may be a lag, and of course there is this major risk that it causes OHSS. So something needs to be done for this. And we know that we are using GnRH triggering only to prevent OHSS. And this meta-analysis of 2009 tells you that it is increasing when you are using HCG. And definitely, there is definitely a decrease in the OHSS value once you are triggering with GnRH agonist. However, just as I said a couple of minutes ago, that with GnRH agonist, there is definitely a negative effect on the luteal phase. And this is what this meta-analysis of 2011 states, that there is definitely a luteal phase deficiency, and therefore additional luteal phase support has to be given in order to support these pregnancies. Hence, came the concept of dual trigger. That was to supplement the deficient luteal phase in such patients in order to increase the pregnancy and live birth rate. Various protocols and different timings and dose of HCG have been used and advocated, but we have not been able to absolve the risk of OHSS completely even by doing this, because we are giving HCG also along with the GnRH agonist, and the risk of miscarriage, of course, is greatly decreased and pregnancy rate is increased. So here is the RCTs which have been done with the GnRH agonist trigger and luteal phase support for fresh ET. And you can see here that if only progesterone was given, then the miscarriage rate is 79% in this study by Humaydan et al. And the clinical pregnancy rate was only 6%. But when 1500 IU of HCG was added, plus OPU plus day 5, and Crinon was also given, then the miscarriage rate fell down to 9% and the pregnancy rate jumped up to 39%. So therefore, it clearly indicates that in all these studies, when they have added HCG, whether it is on the day of OPU or later on, it has led to a better pregnancy rate. However, a recent study by Anderson et al. Suggests that you give a low dose HCG all through from the time of OPU, that is 125 IU. This has not been able to show the same kind of results as this, because the miscarriage rate here was higher, as well as the clinical pregnancy rate, of course, was comparable, but the miscarriage rate was higher. So therefore, we still need to understand how we should, but apparently it seems that if you add progesterone plus HCG, the results are much better. But of course, the risk of hyperstimulation is always there. The other disadvantages of GnRH agonist trigger are suboptimal response or empty follicle syndrome, and of course, immature oocytes. That is very, very interesting and something that we have discovered. This is a study of 8,970 cycles where they found that if the LH is less than 15 milliequivalents at 12 hours after the trigger, then in these patients, there is a lower oocyte retrieval rate, fewer mature oocytes, and fewer frozen embryos to transfer. This is a suboptimal response. And similarly, if the basal LH levels are less than 2, this is a very important marker for differentiating suboptimal responders. So in such cases, a dual trigger is definitely going to increase the yield. So this was a proposal made by this group, Haas et al., where they definitely proposed an algorithm as to how one should proceed when we are talking of this kind of a situation. And you have to look at the basal LH, which should be more than 2, an LH progesterone ratio after the trigger of 2 and above, and an LH after 12 hours of more than 15. If you have any of these, then you are safe. Otherwise, you need to do a double trigger. Otherwise, you will not be getting the oocytes. There is another term now which is coming to fashion, and we are knowing about it, which is called that there is a dual trigger and a double trigger. So a double trigger is something which is proposed by this group again, where the two triggers, the GnRH agonist and the HCG, were given 4 hours apart in order to improve the maturation of the oocytes and thus increasing the number of M2 oocytes. So there is a difference in the two types of roles that LH is playing. One, it is to improve the so HCG is playing to improve the luteal phase support, and in second case, to improve the maturation of the oocyte. So therefore, The GnRH is given along with the HCG 4 hours apart, and the OPU is scheduled similarly at 35 to 36 hours. So hence, in one, you may be giving the HCG at different intervals, and in the other, you're giving it along with the GnRH agonist at 4 hours apart. But some of the groups, as for instance, we are using it together at the same time, not 4 hours apart. The outcome of this dual trigger is quite encouraging, and as you can see over here, the clinical pregnancy rate is much better, the live birth rate also is much better, and the abortion rate is definitely less in the study group. And this is a paper of 2019. So coming to the last part, which is the luteal support, again, this will definitely vary according to the type of the trigger that we are using, the response to stimulation, and whether it is going to be a fresh or a frozen embryo transfer. And if you look at the regimens after HCG trigger and fresh ET, you find that if you are using progesterone versus HCG, there is no difference. However, you get a lower OHSS rate if you are using progesterone alone. And if you're using progesterone plus progesterone and estrogen, there is no difference in the pregnancy rate. So estrogen doesn't seem to be helping in these patients. And progesterone versus progesterone plus GnRH agonist, again, in the progesterone only group, the pregnancy rate was supposedly lower. So this is a Cochrane review of 2015, and this is actually indicating that HCG is helping after the trigger as well. We have already talked about this GnRH agonist trigger, where also if you give HCG, the results are better. Then what about the response to stimulation? So what do we infer from all this information? In the hyperresponder, you need to give progesterone and HCG with caution. The better thing would be to freeze all. In the normal responder, on the other hand, you give progesterone and HCG, and in the poor responder, you can also give progesterone plus HCG. In the frozen embryo transfer cycles, it is estrogen plus progesterone plus HCG. Some people give it, and some people do not like to give HCG because there is no corpus luteum and hence there is no function. Others say HCG has a role in implantation, hence should be given. So to conclude, LH has now emerged as an important and integral part of the entire cycle. Adequate management of LH through the cycle is required to maximize our outcomes, and LH levels must therefore mimic physiological levels in order to achieve success. ICOS is now the mantra of success. Every woman needs to be treated individually, and hence LH must be looked into whenever you're treating your patients of different groups and different backgrounds. So that is what the message is. And I thank you very much for being here with me today. I thank all of you on behalf of my group. We all work together in India. Thank you very much for having me here once again. And before I leave, I would like to invite all of you to my society meeting, that is the Indian Fertility Society meeting, where we are having a huge group of foreign KOLs or from all across the globe. And if you look at this carefully, you will see Dr. Hassan Salam, Dr. Michelle, and Dr. Johnny Awad also as a part of the team here, our invitees. So please do look at this brochure, look at this site, and we hope to see you all with us between the 4th and 6th of December. Thank you very much for your attention. Thank you so much.
Okay, thank you very much, Dr. Malik, Dr. Sonia. It's for a beautiful presentation and a beautiful revision of all the role of LH. We have, I will give you a couple of questions now, and we leave the rest for the end. One of the questions is about the LH. Does the high LH really, is the high LH on the day of trigger? There is a question on what is OPU. Of course, it's ovum pickup. Somebody was asking. There is another question actually from Dr. Shafez from Peru, and we have people from Dubai and from different places. But I'm just going to ask the question now. The high LH, is it really detrimental to the results? Because you probably know the work of Professor Messinis, Ioannis Messinis, who found that particularly with GnRH antagonist protocols, it only prevents the LH rise in about 50% of the cases. There are many patients where you have the rise of LH and still the patient becomes pregnant in the same cycle. So what is your view about that?
Actually, this is a very controversial topic. Controversial, opinions differ. And as you said, there is this study. But I want to ask the House as well as you, why do we do ovarian drilling if we are so not so bothered about bringing down the LH? What is the role of surgery then? It is an option for patients where they are either cannot afford gonadotropins, or there are clomiphene resistant, or the AMH is high and the LH. These are the indications for ovarian drilling. So then why are we doing ovarian drilling in such patients if LH has got no role to play? And LH comes down when we are down regulating. So there are subgroups of women. I believe that there are subgroups of women. There are women where the LH is not going to come down no matter what you do. Even if you do an antagonist cycle, sometimes you find that these are the patients who get stuck after some time, the growth is stopped. So they are actually the ones where LH does seem to be having a problem because it has not gone down. If you do the LH levels on day 6 of stimulation, you will find they are still high. They haven't come down. Majority of the cases when you're giving antagonist cycles, the LH levels come down, but here they don't. So there is a subset where I think it is required to down-regulate these, and I generally do it in my practice.
Yeah.
Despite the fact that people say that it's a choice, because majority of the PCOS you're going to in any case freeze the cycle. So the endometrial response to LH doesn't matter at all. It's not the endometrium, but the follicle themselves are also going to be affected.
Yeah.
That's my feeling.
Yeah, as you say, I mean, most of people do as you do, and you're a leader in the field, and we have
No,
to take your advice. But I think we leave the rest of the questions for the end of the webinar. And now I leave the microphone and the video to Dr. Wafa Benjamin to introduce the next speaker.
thank
Dr.
you very
Wafa.
much for this. Thank you very much.
Thank you, Dr. Sonia.
Thank you.
Good evening, everyone. Thank you so much, Professor Sonia, for the very interesting talk. It will be much appreciated if you can kindly just answer the so many questions in the question and the answer. If you can type some answers for the questions, and the remaining we will take at the end of the webinar. It's my great pleasure to introduce our next distinguished speaker, Dr. Tamer Nefa. Dr. Tamer is a consultant in fertility and assisted reproduction in Create Fertility, Manchester, UK. He's going to talk about an interesting topic, which is recurrent implantation failure and update. The floor is yours, Doctor.
Thank you very much, Mr. Chairman. Thank you very much for inviting me. It's an honor and a pleasure. I've learned everything in the University of Alexandria before moving to the UK and done my research there, and it's an honor to be here. Shall I share my screen? So yeah, the topic of my talk today is about embryo implantation and recurrent implantation failure, embryo implantation for clinicians. And this is the general outline of the talk. So a glimpse of embryo implantation as in assisted conception, some definitions, and what's the current state of evidence regarding what improves implantation and how we tackle recurrent implantation failure. Big subject. We'll have highlights today. Outline some of the challenges and consequently some of the future trends, and then we draw a conclusion. If you look at any IVF lab's KPI, you will realize that the pregnancy rate, the outcome, is closely related to the implantation. Over the years, we have optimized and near perfected the art of growing and collecting eggs. From ladies, we have very good fertilization rates. We can create embryos for almost all ladies, but then you hit a brick wall, a bottleneck, when you put the embryos back, and it is the progress of success in IVF that depends on development, understanding, and tackling implantation. On a global level, you can see on the left the very sharp rise. This is the United States data, but it applies everywhere. The very sharp rise of success as we were developing the IVF early on and the pioneers, and then everything plateaued. There is a reason for the recent decline, but definitely we blame implantation for most of this. And if you Google, if you PubMed embryo implantation research, you will find this top right figure with maybe 17,000 papers in the maybe 10 years. And it's just, there is an explosion of research, and we have to make sense of this. You know you are in trouble when you do not agree on a definition. This is a table is from the recent paper, the Canadian guidelines published in RBM Online just recently. And you can see that there are many definitions as to what constitutes a recurrent implantation failure, because it's a fairly new phenomenon. It's a phenomenon that started to occur when we optimized everything else in IVF, or nearly, and that's why we're now focusing on implantation. This is the definition we used when we were in Sheffield and recently in Manchester, and it focuses on patients that are under 40 years for evident reasons to exclude the aneuploidies, and it is putting 4 embryos or more consecutively. You can choose your pick, whether you want it to be 2 blastocysts and 4 cleavage stage embryos, or 4 embryos in general. People differ upon that, but the emphasis here is that they are all of good quality, and it doesn't really matter whether you transfer these embryos in fresh cycles or frozen cycles, because as we know, they should have equivalent success rates. And if you focus more on the research, you will find that it's logically divided into research attempting to understand more and treat the embryo factor or the endometrial factor. Well, that is whether that is about obtaining the optimal embryo by clinically getting the best eggs and sperms, predicting which one is the best embryo among all the embryos you have, or facilitate the embryo implantation, for example, like assisted hatching or so forth, or focusing on the endometrial factor, the maternal factor. And this is much more investigated, although it is not necessarily the main factor in recurrent implantation failure, as we will see. The embryo factor carries huge weight and it needs more investigation. But on the maternal side, there is the molecular study of the endometrium, and the endometrium is not a homogeneous compartment. The endometrial epithelium is very different from the endometrial stroma, different functions at different phases of the cycle, and the failure can be in any of these 2 compartments. There are the anatomical problems, there are the systematic environment of the mom, and how to optimally prepare the endometrium and how to time the embryo transfer. So these are the axes that I found that all the research is focused on. If you go a little bit deeper, you will find that obtaining a better embryo means obtaining better eggs and better sperms. Better eggs is mainly a clinical problem that starts with the patient selection and preparation. Which protocol are we going to use? What medications for how long? Timing of trigger, use of adjuvants, how to monitor, etc., etc. And the better you are, the better eggs you will have. On the sperm side, it's mainly focused on the lifestyle and giving the gentleman some pre-treatments in an attempt to improve the quality of the sperms. A diagnostic test, which is the DNA fragmentation, has been up and around for quite some time, with some debateful outcomes, and how to improve the DNA fragmentation and what impact it really has on embryo implantation. After egg collection, there is the better handling of gametes. What do we do? How do we do IVF or ICSI? Do we select sperms through high resolution IMSI? Do we do assisted hatching? And how to prepare for embryo transfer? And also better selection for embryos, whether this is the usual grading or the time-lapse imaging, or recently the genetic testing of the embryos, the PGT-A for aneuploidies. Finally, you will find lots of research focusing on the endometrial factor, whether this is the clinical side, ultrasonographic assessment, or hysteroscopic assessment for pathologies, or even MRI for adenomyosis, and better preparation of the endometrium and better timing of embryo transfer, whether this is the clinical timing or molecular attempts to time the endometrium better, like the endometrial receptivity assay. And of course, lots of local markers for endometritis, natural killer cells, endometrial scratch, the vaginal microbiome, all of these will touch upon some of them. Some of them my distinguished professors and colleagues later on this session will touch upon them. And of course, the systemic markers like the thrombophilia screening, vitamin D, hormonal profiling, and immune markers. So let's get a taste of what the evidence looks like. One of the commonest tests that are done for patients that have recurrent implantation failure, and I found this in most all units I worked in, here in Egypt, everywhere, is the thrombophilia screening and the focus on the antiphospholipid antibodies, and should we test these patients and should we treat them? And this is a retrospective, quite a large retrospective analysis, just trying to compare patients that have thrombophilia screening and patients who have received anticoagulation as a result of this. And the conclusion, as you can see here with underlined, is quite disappointing. And this is a trend that you will find in lots of attempts to create evidence for a recurrent implantation failure. The data suggests that neither screening of thrombophilia nor anticoagulation is indicated on cases of unexplained reproductive failure as recurrent implantation failure in this instance. There's been some promising figures around the factor V Leiden and lupus anticoagulant, but these were not enough to stand robustly in the conclusion. Hysteroscopy, one of the salient investigative criteria that patients are advised with after several cycles of IVF. This will be discussed in detail in a later lecture, but I just would mention here the trophy trial by Dr. Touhi in Guy's and St. Thomas Hospital and all the team. This is a multi-center study. I think there are 6 or 7 across Europe and the UK. 350 patients went for hysteroscopy, 350 patients almost no hysteroscopy, no difference. Even though some of the abnormalities were tackled during the hysteroscopy, but there was no apparent difference. And this is a list of the abnormalities they have come across and they've tried to tackle in about 300 women, did not improve the implantation rate in these women. And as you can see, many of the centers are leaning towards favor no hysteroscopy on the graph rather than favors hysteroscopy. But the result is it doesn't really help. The endometrial receptivity assay, and this was we had very high hopes for that. We used it in our unit for about 2 or 3 years. The way it works, so you do frozen embryo transfers only, medicated frozen embryo transfers. You prepare the patient precisely as if you are doing an embryo transfer. And at the day you would do the embryo transfer, you would do a PPL biopsy, put it in the RNA later, which is the type of media that preserves the transcripts, the RNA, and ship it to Genomics in Spain or in the UK or wherever. And they would come back telling you if this profile is receptive endometrium or no, it's a bit too early, pre-receptive or post-receptive. They've been brave enough to even suggest 12 hours window, do the transfer 12 hours later, do the transfer 4 hours earlier or whatever. Quite expensive as well. It costs a patient typically maybe £1,000 to do this test. And if it's abnormal, they advise to repeat it, which is another £1,000. This is a paper which is published, I think this was 2019, and it attempted to see once and for all if endometrial receptivity array would be of benefit, and they used, quite smartly, euploid embryos after genetic testing so as to exclude a confounding variable of some normal and some abnormal embryos being used, and they used oocyte donation so that to basically rely on young donors who with high reproductive potential. And as you can see, the conclusion, last line here, the performance of endometrial receptivity assay did not improve the pregnancy outcome, and maybe more research should be needed. And I must say that it is now falling out of favor given its high price and the lack of improvement. This was the design of the study, and as you can see, this is the conclusion down here, whether they used euploid embryos or donor transfer. Another thing that is coming up quite nicely and quite promising, but has lots and lots of technical issues with it, is the microbiome. And the general hypothesis here is quite clear. The uterine cavity is not a sterile environment, as everyone assumed. There are some microorganisms living there, and if you have got the right soup of microorganisms, then you are more likely to implant embryos. And if you have got the wrong soup of microorganisms, then possibly you need some help, although what this help is still debatable. So yeah, so we would just do a uterine swab, and this uterine swab will be sent, and using a PCR polymerase chain reaction, they would amplify the genomes of all the bacteria, and they would identify approximately what type of bacteria are dominant here, and then profile you accordingly. Is this favorable for implantation or not favorable for implantation? Still new, haven't done lots of these, but the technical issues are astounding. And that's why I'm quoting this paper here from the Brussels group. And they basically compared the microbiome of ladies without ovarian stimulation to ladies with ovarian stimulation, and it was different. So just the induction of ovulation or the stimulation of the ovaries and the change in the hormonal environment was enough to alter this. And also the uterine cavity has a very low load of microorganisms compared to the vagina and cervix. So it's a technical challenge not to get contamination in these patients, because you can easily carry a contaminant from the lower uterine, the lower genital tract up to the upper genital tract and cause abnormal false results. So it is maybe promising, but it's still miles and miles away from developing from being a marker and of clinical use. And to add before we move on, I just want to say that even if you've got the abnormal flora or the abnormal microbiome there, there is still a lot of work to be done as to how to alter it and come up with a more favorable microbiome, and then prove the effectiveness of this in randomized controlled prospective trials, of course. And that's why when you come to look at guidelines and attempt to find evidence and to pull lots of information, you find things like what we have here. This is a very useful and very recent, as we said, the Canadian guideline. And they attempted to look at lots of diagnostic and interventional approaches to patients with recurrent implantation failure. As you can see here, testing the cavity with the hysteroscopy, thrombophilia screening, immunological testing of the mom, systemic or local, karyotype for both parents, DNA fragmentation, endometrial receptivity assay, genetic testing. They did not do the microbiome. I added it here because I wanted to mention it. Also interventional, the endometrial scratch using anticoagulants like low molecular weight heparin and aspirin, and using immunomodulators, systemic immunomodulators, immunoglobulin, intralipid steroids, or local immunomodulator like the granulocyte CSF. This is the short summary. The karyotype and the genetic testing of the embryo pre-implantation genetic testing of aneuploidies are quite promising, but the others are not. There's no evidence to support offering them. And this is how they even word that. So this is the current state of evidence at the minute. And we'll see why is this is the evidence and what can we do about it. So what can be offered is on the left, the karyotype testing and the genetic testing. Others are mainly not advisable, or if advisable, then they are in a research setting only. In the United Kingdom, we are very much governed by the Human Fertilization and Embryo Authority. It's a very, very well regulated practice, and you have to abide by the rules. And the HFEA, the short of the Human Fertilization and Embryo Authority, they check you and they come and audit you. And this is, and they have issued what they call a traffic light system. So if something you need to do, you check with HFEA and see if this is coded green, which means do it, it's good. amber, which means we're not really sure this is necessary, or red, like don't do it. And it carries consequences with that. So as you'd be able to see that many of the interventions we do for recurrent implantation failure are coated red, which further limits what we use. I want to draw your attention to a paper. It's a small paper, but I find it very interesting, published by Nick Macklin, now in London, and his group. And they wanted to see in patients with recurrent implantation failure if they could in any way predict using all the tools. It was like a brute force approach, using everything. They threw at these patients everything. As you can see here, they just had 86 patients with a history of recurrent implantation failure, 37 starting their first fertility treatment, as to compare. And they did markers of chronic endometritis, they did endometrial biopsy, the microbiome, you name it, hormonal profile, genetic testing for embryos, and they just did their best for them. No, they didn't do the genetic testing for embryos, I'm sorry. All endometrial investigations have been done. And here they are, again, the hormonal levels, vitamin D, the thyroid function, natural killer cells, markers of endometritis, microbiome, and ERA test. All of them, they have done them for these patients in an attempt to try to find a test or a combination of tests that would be quite predictive of embryo implantation in these difficult patients. Although they had some promising results with the vitamin D, serum progesterone level, and microbiome, and maybe a bit with chronic endometritis, it was very clear that a single test or treatment for an endometrial factor is unlikely to be clinically effective, which may be for several causes. Among one of them is the notorious capacity of human embryos to be aneuploid. This is a paper published in Nature Medicine quite a few years ago about the aneuploidy and cell-to-cell variability of the human embryos, and about 70% of the human embryos had some form of aneuploidy or others. As you can see, sometimes entire chromosome arm imbalances in up to 40%, or just terminal segments, so different types. It's a very fantastic paper to read, but it just shows you that though we are focusing and fixating on the endometrium or the soil, as you may call it, rather than the seed, you have to pay attention that the seed can be the cause of the majority of the problems. And testing the seed is difficult, and it has its own issues, which will be discussed in a separate lecture today. But one of the ways forward could be the non-invasive testing of the embryos using the microfluidics and new ways of culturing the embryos. This is subject of research. Anyway, recurrent implantation failure is a very challenging problem. Mainly, it is a new problem, and we don't understand a lot about the cellular and subcellular and molecular mechanisms in humans. Lots and lots of research in animal models, but it's very, very different, one mammal from the other. And I can tell you this because I've tried them all, and there is limited high-quality evidence. It is a heterogeneous problem. One of the main problems that we don't have high quality research is that we are trying to test apples and oranges together. Not all recurrent implantation failure patients are the same pathology, and that's why not all of them will respond to the same approach. We must learn how to stratify these patients and subgroup them. With the high emotional tone in an IVF clinic and your patient crying after several failed cycles of IVF, there is a blurring of the line in clinical practice between what is experimental and what is evidence-based. And this is made even more complex by the fact that the policymakers and the guidelines are directed at nations, not at an individualized level. And of course, evidence changes. That's why the way forward should be more understanding of the basics to generate hypotheses, better clinical trials, not at all the recurrent implantation failure patients, but attempting to smartly subgroup them so that the impact of a specific intervention would be more clear, and continuously updating our evidence and following the changing evidence. Meantime, we have to maintain the transparency with the patient and be clear about what's a bright idea and experimental versus what is established fact, and be aware of the cost rationality of this and balance the benefits of an intervention with the potential harm and keep the discussion going. Thank you very much.
Thank you so much, Professor Nafa, for the very interesting talk. I think there is many questions in the questions and the answers. However, because of the sake of time, we may just go for the next presentation, and we will take all the questions at the end of the webinar. It's my great pleasure to introduce our next speaker, Professor Timur Gorgan. Professor Gorgan is a professor of obstetric and gynecology, Hacettepe University in Ankara. He is the president of the Turkish Society of the Reproductive Medicine and the past president of the International Society of the IVF. And he's going to talk about a very interesting topic as well, in continuation to the previous one, which is hysteroscopic endometrial injury for the treatment of repeated implantation failure. Professor Gorgan, please. We can't hear you.
Having some trouble. You hear? Yes. I know that.
Yes. Yeah.
This is the problem.
Dr. Nafa, it would be great if you can just answer some of the questions in the questions and the answer. You can type the answer, please?
Pleasure. Will do.
Thank you so much. And the remaining questions we will take at the end of the webinar.
Professor Gorgan, we cannot hear you. Are you with us?
I know.
We cannot
I'm
hear
here
you.
trying to, yeah.
I think he's trying to share his screen, Professor Hassan.
Okay. You try share your screen. By the time, maybe we can ask Professor Tamer for some questions. Professor Nafa. There is a question about the supplements. Somebody is asking, Dr. Sam Raouf is asking, what sort of supplements would you like to try and name any of them? So do you have anything in particular?
Yeah, personally speaking, the folic acid and vitamin D, because I live in a country without sun almost, are just almost universal patients. But other than this, all the advertised maybe supplements, they do not have any evidence behind them. So you may as well pick any multivitamin like any other, in my opinion. I have not come across a single supplement that is that has proved itself.
Yeah. Another question is from Dr. Benjamin Gadda. I think he's from I can't remember where he's from, but he does. Does time lapse improve outcome in patients with repeated implantation failure? This is one of the questions.
Unfortunately not. The evidence so far is that it has not improved the outcome.
And the other thing, what about the use of maximum implantation potential, which is an area selected in the endometrial cavity using a 3-dimension scan?
Well, again, quite interesting. I'm keeping an eye on it, but I still am waiting for the evidence. At the end of the day, there's no evidence that...
Nasıl bağlanacağım? Görünüyor mu şimdi?
Sorry? Hello?
Yes, all right. I think Professor Gurgan, now we can see your slide, Professor Gurgan, so you can start if you like. But please.
Can you hear me?
Yes, we can hear you. Maybe you can go on the, enlarge the screen if you like. Put it on, okay.
Just a minute. Just a minute. Hi.
Tamam. We cannot hear you properly, Professor Gurgan. There is something with the sound.
Professor Gordon, I'm afraid the voice is not so clear. It may be the internet connectivity.
Don't hear me, right?
Yes, we
Now
can
we
hear you,
can
but
hear
the
you.
voice is interrupted.
Dr. Gurgan, Professor Gurgan. No, Professor Gurgan, we cannot hear you. Yesterday the voice was very good. Why is it today? Did you change the place where you're talking from?
Professor Hassan, do you think we may go for the next presentation?
Yes, I think we can go with Professor
Until Professor Gorgan, can you fix your internet connection, please?
Can I try to
Send him a message on the chat. He probably can't hear you.
Professor Gurgan, can you unshare your screen? Can you unshare your screen? So that...
Because you may need to disconnect and try connecting again, please. And until that, we may go for the Professor Ilyas.
مي ممكن تعملي له انشير ولا ما ينفعش؟
هذا افتح عمال.
Professor Salam, can you introduce the next speaker?
Yes, but we need to remove the screen of Professor Gurgan.
I think if yes.
Okay, ladies and gentlemen, until Professor Gurgan fixes his problem, I would like to say that it gives me a great pleasure to introduce Professor Elias Dahtou. Professor Dahtou, who is the founder and medical director of the Assisted Reproduction Center at the Centre Hospitalier Universitaire de Saint-Justine in Montreal in Canada. He's also an assistant professor in the Department of Obstetrics and Gynecology at the University of Montreal. He's very well known. He's in the field of assisted reproduction, as we all know, and particularly in the area of pre-implantation genetic testing and diagnosis. And it gives you a great pleasure to introduce him. And he's going to talk to us and give us an update on pre-implantation genetic testing for aneuploidy. Professor Dahtou, please. The floor is yours.
So I'm trying, yeah, hi, how are you? So I will share now my presentation. Do you have it or no?
Not yet.
Okay. I will try again. Okay. Yeah.
Yes, but please.
Okay, excellent. So I will say good night for everyone. Good afternoon here. We are still at 3:15 in Montreal. So you are hearing me well, Dr. Hassan? Hello?
Yes.
Yes, we can hear you. Yes.
So I want to first thank Dr. Hassan for inviting me for this really great webinar and to be part of this talk with great speakers. So it's my pleasure, really. So just I will begin with my disclosure. I have nothing to disclose for this presentation. Just to tell you that I'm practicing in a public ART center. Though IVF is not covered by the by the public health system, if we do PGTA in our center, we don't charge anything. In fact, we charge something for the patient, but there is no profit. So I don't have anything to disclose for this presentation. So what are the learning objectives today? So we'll see together what is the purpose of PGTA, why we are doing pre-implantation genetic testing for aneuploidy, what's the aim, and mainly we'll see together what are the clinical outcomes. So what are the recent evidence, and then we'll finish by maybe we'll see together and we put some subgroups of patients that might benefit from this technology. So just for definition, you recently there was a change in definition. Previously it was this technology was known as pre-implantation genetic screening. Now it's the better terminology, I think, pre-implantation genetic testing for aneuploidy, because it's more testing for aneuploidy. And then at the same time, you are doing screening for all the embryos for aneuploidy. So it was first, the indication was advanced maternal age, recurrent implantation failure, recurrent pregnancy loss, and for sure, it's an invasive embryo selection method compared to, for example, the blast culture and the time lapse, which are non-invasive. There is no biopsy from this technology. So what's the process? We do for sure IVF. Most of the time we are doing ICSI, but we can do even regular IVF, conventional IVF when we do PGTA. We do the embryo biopsy. Nowadays we do it with trophectoderm biopsy. We remove 5 to 10 cells. We are opening is the zona pellucida at day 3. We continue the embryo culture. Then there was, as you see, a herniated here cells, and we remove ideally 5 to 10 cells. Less than that, we might have misdiagnosis, and more than 10 cells, we might harm the embryo. Then we perform the genetic analysis by different platforms, and finally, we'll transfer one single embryo at a time, and we put it inside the uterus. So a quiz for everyone. What do you think the most important factor in IVF success? Is it ovarian stimulation? Is it embryo genetic status, or the endometrial receptivity window of implantation, or embryo transfer technique? For sure, if you think the four are very important factors for success, but in my opinion, the embryo genetic status is the most important factor. Why? And this is coming also from egg donation. If we take a patient 40 years old, she has excellent ovarian stimulation, perfect ovarian stimulation, excellent endometrial receptivity, we perform an excellent embryo technique, we can achieve maximum 20-25%. If this patient will go for egg donation, so less aneuploidy rate for this egg, we can achieve higher success, around 50 to 60%. So this is why embryo genetic status, in my opinion, and it's confirmed by firm data, that this is the main factor for success. So a basic principle in IVF, whenever you have a single live birth, you should have a diploid euploid embryo transferred into a receptive endometrium. Again, implantation is very important, as the previous 2 speakers, and we'll looking forward to the next speaker to see about implantation too. So what is the aim of PGTA? It's the transfer, a euploid embryo transfer, and it's an invasive embryo selection method because it's about embryo biopsy and genetic analysis. For sure, as we all know, that aneuploidy rates will increase with advanced reproductive age, reaching from 30% in the below 35 to 90% around 42 years of age. And this will impact the implantation rate, high from 50% in young patients to 6% or less in older patients more than 42 years old. Very interesting paper from Franciac, the group of Richard Scott, more than 15,000 trophectoderm biopsy. You can see the aneuploidy rate start being ideally the lowest between the age of 25 and 30, and then it will rise up to 80-90% more than 42 years old. And this is the percentage of having a patient with no euploid embryo. And this is very important in counseling any patient who will choose to go for PGTA. She will tell you, and you need to tell her what is her risk of having no euploid embryo for transfer. And this is an excellent paper. So up to 60-70% of embryos will be aneuploid, and she will have no euploid embryo for transfer. And this is the main limiting factor when we're doing PGTA, because every patient most probably will not have a normal euploid embryo to transfer. And if she accepts this fact, she can do PGTA. Otherwise, we should not do it. Another paper, if you see if we have a normal euploid embryo, irrespective of age, we can have the same implantation rate up to 50%. The challenge again here is to find that normal euploid embryo for transfer. And this is a major challenge, especially in older patients having low ovarian reserve and having higher aneuploidy rate. So let's go to history. As you all know, that PGTA at the beginning was first done by fish on day 3 embryo. And there was an excellent paper in New England Journal of Medicine by Mastenbrook that showed that even on advanced maternal age, those patients were the targeted patient for PGTA. There was even a decrease in live birth rate, and a meta-analysis published by the same group in 2011 in Human Reproduction Update showed that there is no really benefit. There is even harm if you do PGTA, PGS by fish on day 3. So we cannot do it, it's over, and this is now history. So what are the paradigm shift in PGTA? 2 things. First, they change for blastocyst biopsy. So now we are doing blastocyst culture, and then we are retrieving 5 to 10 cells from trophectoderm. So ideally and theoretically, there is less mosaicism, so less error rate with blast culture. It seems that this technology, this biopsy, has no impact on implantation, so it's harmless for the embryo, at least in experience sense. So 2 papers from Scott, the only 2 papers, one randomized, one non-selected selection study showed that there is no harm by doing embryo biopsy on implantation rates. So this is the only randomized trial. They compared day 3. If you have a biopsy on day 3, you will at least have a 40% decrease in implantation rates. Compared when you have day 5 biopsy, there is no impact on implantation, at least again in experience sense. What are the technologies? All technology fits, it's over. It can detect only between 5 and 12 chromosomes. Now we are moving to what we call comprehensive chromosome screening. So we are testing for all the chromosomes, 24 chromosomes, including X and Y. We can do it by CGH, SNP, qPCR, and recently with next generation sequencing, NGS technology. So let's go to the evidence. Is there any evidence? Unfortunately, most of the published studies are being prospective, retrospective, scored studies. There are only 6 randomized trials in the literature, and I'm not aware of any ongoing trial on PGTA. So the first 3 trials were one with CGH, 2 with qPCR, and 1 only with NGS, a recent STAR trial. And again, 2 from the same group with PCR. This is coming from Richard Scott. 1 randomized trial on day 3. This is the Rubio trial. 1 on polar bodies. This is the Esri trial, the Esteem trial. And 4 studies, RCTs, we are doing biopsy on day 5, day 6, blast biopsy. So in 2015, we published the first systematic review on RBM Online, which is already cited by 109 times. So we, at the same year, we published the Canadian guidelines on PGD and PGS. And what was the conclusion at that time? That PGS or PGTA can improve implantation rate when we do it with CCS on blastocyst biopsy. And this is only in good prognosis patients, because all these patients from this study were high ovarian reserve patients having high number of eggs, high number of blasts, and high number of embryos produced between even the PGTA group and the control group. Then we published again the same year our meta-analysis. And if you see the title, we did not say that PGTA improves live birth rate. And this is really wrong. We say that only this technology will improve embryo selection. So if you have high number of embryos you want to select, maybe PGTA will give you a better selection, and especially this is only for the first transfer. If you go for cumulative live births, tested, non-tested, I think at least the non-tested group will have the same live birth rate, or even will be higher than PGTA. So if you're looking for a cumulative pregnancy rate, don't do PGTA. If you're looking for the first transfer, maybe the second transfer with high number of embryos, maybe again PGTA will give you a better results for selected patient with high ovarian reserve. So this study has been chosen by the American Board of OBGYN for RE-EI certification in 2018. So I think it's an excellent paper to still the same, if you take this conclusion back to 2015, and if you apply it on our today's practice, this is all the way, nothing have changed, still good prognosis patient will benefit only from this technology. If you look to our meta-analysis, we divided in randomized trials and observational studies. Unfortunately, the patient on which we are doing the worldwide practice on PGTA, advanced maternal age, recurrent implantation failure, recurrent pregnancy loss, it was only included on observational studies. No single randomized trials include those high-risk patients for aneuploidy. Why? Because I think authors and researchers are convinced that this technology cannot improve success rate, especially in patients with low ovarian reserve, with diminished ovarian reserve. Again, the improvement were noticed only in centers who have high experience of PGTA and a broad experience in blastocyst biopsy. So if you see improvement from this randomized trials, you will have higher implantation rate and higher even sustained implantation rate after beyond 20 weeks. So this is the Rubio trial on 2017 from day 3 with CCS, with CGH. So there was improvement in live birth rate for the first embryo transfer and even per patient. But when they calculated the live birth rate for in 6 months, there was no improvement after 2 or 3 transfers. And if there is any benefit of PGTA, it will be for your first transfer. So maybe time to pregnancy will be shortened, and maybe your miscarriage rates will be less. This is the only advantage if you're doing PGTA. Again, this is the European trial. They did polar body biopsy and CGH, and the primary outcome was the live birth rate after 1 year. It was equal in both arms, PGTA and control arms. So, but time to pregnancy was less with PGTA, and they had higher number of ESAT in this in the study group. So maybe PGTA will be an excellent selection tool if you want to go single embryo, if you want to do single embryo transfer. Finally, it was long-awaited trial, the STAR trial, which really will talk about our daily practice on PGTA. So they single embryo transfer in both arms. They did it by NGS technology, the most common used technology nowadays, and then blastocyst biopsy. And this is a multi-center trial, different centers, 4 countries, 34 clinical sites, and this is the largest RCT published so far. And if you look against expectation, against the purpose of the study, because the researchers were proponent of PGTA, they had no improvement if you take all the patients, all ages, between 25 and 40 years old. There was no improvement in ongoing pregnancy rates beyond 20 weeks. Then they made a post hoc analysis for patients between 35 and 40 years, and they show little benefit here, 50% compared to 37%, and this is only per embryo transfer. Once you calculated per cycle started, there was no improvement. Why? Because many patients on the PGTA arm, at least 20 to 30% in the study did not have any embryo transfer. So maybe PGTA is associated with embryo wastage. Why? Because with NGS, we are having mosaicism, and then these mosaic embryo, if they are being discarded, unfortunately, we are decreasing the live birth rate and the pregnancy rate, because these embryos at one time, maybe the embryos between 20 to 50% of mosaic levels, they can be transferred and they can give live birth. And if we don't transfer these embryos, we can decrease the pregnancy rate by PGTA. And this is really the drawback of this technology. And again, against expectation, miscarriage rate was not different between PGTA group and control group. So this is my last paper. It's submitted, it's under review. Hopefully it will be accepted. And if you look to all the RCTs published so far, look at the number of eggs. Those patients have high ovarian reserve. At least you can even see the Monet trial, the STAR trial, 18 eggs, 7.5 blastocysts from PGTA and the control arm. And to be honest, I don't see this in my clinical practice. I see between 2 and 4 blastocysts. So maybe if you're going to do PGTA and you need any improvement, you should select your patient, do it between 34 and 40 years of age, and especially for patient with high ovarian reserve, having at least 3 blastocysts or more to benefit from this technology. What's really, this is the first paper showing that if you transfer a mosaic embryo, you can have live birth rates from Greco group in Italy. And this was the first paper showing that maybe we have a big misdiagnosis with PGTA. So it's not a perfect technology. Still, we can have a high misdiagnosis rate, and maybe we can discard normal embryos that can give rise to a normal live birth by being aneuploid or mosaic tested by this technology. So just a small, some words about mosaic. They are divided by low level when there is 20 to 50% aneuploid cells in the biopsy, and between high level 50 to 80%. And you should look at the specific chromosome involved. If you have, for example, a mosaic for trisomy 18, 21, or Turner, legally, you can have a problem if you're going to transfer these embryos. And if you don't have any euploid embryo, the patient should go excellent and complete genetic counseling even before transfer. And if you have any established pregnancy, you should go for prenatal diagnosis. And prenatal diagnosis should ideally be done by amniocentesis, not by chorionic villus sampling. Why? Because when you do trophectoderm biopsy and when you have mosaic, this is corresponding to placenta. So if you do CVS, you cannot have the good information on the fetus. So what are the prerequisites for PGTA by CCS? Again, you should have an experience in extended embryo culture. You should have, every clinic should define its percentage of blastulation. In our clinic, it's 85%. Excellent experience in blastocyst stage biopsy. Retrieve 5 to 10 cells, not less, not more. And you need to have a validated and tested CCS platform. And you should have a patient with high ovarian reserve producing enough, a good number of eggs and more than 2 or 3 blastocysts to be biopsied. And for sure, we are doing now frozen embryo transfer, so you should have an excellent vitrification system. So what are my take-home messages today? What's the current evidence of PGTA? So some questions. Does it increase live birth rate by fish on day 3? So it's no, and the evidence is very high. Does it increase implantation rates and improve embryo selection by CCS on day 5? Yes, only for good prognosis patient, for patient with high ovarian reserve. Does it increase live birth rate by CCS on day 5 and day 3? This is Rubio trial, yes, only again for good prognosis patient. And for advanced maternal age patient between 35 and 40 years with high ovarian reserve. Does it increase in live birth rates in recurrent implantation failure and RPL? Answer is pending, we don't know, but we have just a level 2B evidence from cohort studies. And does it increase live birth rates in poor responders? Probably not, and this is my opinion. So again, PGTA is not for every patient, remember this, and definitely not for every IVF practice. So thank you very much. And if you want to have an excellent talk about mosaic embryos, so don't miss, again, sorry, Sonia, because you have the same meeting at the same time, but with Zoom, you can be at the two meetings at the same time. So I'm presenting about mosaic embryo. I presented already at ASRM. So come and join us to MEFS to see if we have to discard or to transfer a mosaic embryo. Thank you very much.
Thank you very much, Professor Dahdoh, for a beautiful presentation. And we have a couple of questions. I will ask you one question, and then we will see if Professor Gurgan is ready or not. Now,
yeah.
the questions we have here is, how do you explain the work of Greco, who put back, I think they were 18 mosaic embryos, and then he obtained 6 normal fetuses, therefore concluding that maybe what we are doing with the PGTA is that we just are discarding embryos which may have achieved a good pregnancy with a good outcome.
Yeah, exactly. In fact, if you want to have an explanation why mosaic embryo can give rise to a normal live birth, there is 2 explanations. First, you have a misdiagnosis. It means that when you do the biopsy at one site, it does not mean that this site is representative of the whole embryo. Many studies have shown if you repeat these biopsies on different sites, even on the trophectoderm, for mosaic diagnosis, you have less than 40% concordance rate. So in 60% of the cases, you have another diagnosis. This is first. Second, there is an excellent paper in Nature recently published that showed that there is self-correction between the blastocyst stage till even 12 days after ovulation, and there is most probably an apoptosis taking place that will get rid of the aneuploid cells, and euploid cells, which are the best cells, will continue to grow, and will give birth to a normal fetus. This is the 2 explanations that I can give you.
Yes, but this is a good explanation. But then people will ask, so what's the point of doing PGTA then? If
exactly, in fact, Hassan, in our center, we don't do PGTA with NGS because we have in-house the CGH platform, and we are really lucky because the CGH platform does not detect mosaic embryo less than 50%. So whenever you have more than 50%, so this is high-level mosaic by NGS, so you should not transfer it. And the other point, you should look at the specific chromosome involved, because if you have trisomy 13, trisomy 16, 18, 21, 22, and X and Y, you should not transfer unless you have an excellent genetic counseling for the patient, and because she doesn't have any euploid embryo, and she is not willing to do another PGTA cycle, she can transfer it, but you should have an early prenatal diagnosis. And in our practice, we never transfer a trisomy 21, even mosaic, just to make things clear. So it's an ongoing area of research, Hassan. So the best paper will be to transfer after proper counseling and after having a approval by the ethical committee, and then taking these pregnancies and to correlate with the postnatal even karyotype and the prenatal karyotype. And to my knowledge, these studies are lacking for the moment.
Yeah, I actually would like to ask Professor Tamer and Dr. Sonia also if they have an opinion about the matter. Dr. Nafi.
Well, basically, the limitations of testing some cells from a very complex embryo are evident. And I agree with Dr. Dahdoh that we now know that the embryos replace the bad cells with the good ones, which means we may be condemning good embryos. and having false results. And that's why I think the future may lie in non-invasive testing of embryos through the embryo culture systems and microfluidics. I think this may prove to be a more representative of the real functionality of the embryo as a whole, rather than a biopsy from one side.
So you don't do PGTA in Manchester?
We do. PGTA is uncommon. We do it very uncommonly, but we do not tell the patient that this is necessarily. We counsel them about interpretation, about the mosaicism, and about the possibility of us having false interpretation and false outcome. But some patients with repeated cycles, that they have done many cycles, come with a determination to do PGTA, and so we give it to them.
Yeah. And Dr. Sonia, do you do PGTA? Well, Professor Elias has said it's not for every center, it's not for everybody. It needs
Professor Hassan, even in our center, we have an excellent genetic lab, excellent genetic department. We are doing PGTA less than 5% of our practice.
I see.
Because once we counsel properly the patient, we do many PGTM and PGT-SR. This is a different thing. These patients have already genetic or single gene mutation. This is different thing. They will go for it to have not an interruption of medical termination of pregnancy. This is a different option. Professor Hassan, I have 2 more slides. Question if Dr. Timur is not ready.
Well, actually, Dr. Timur will not be able to join us. I think he has a very big problem, and he just phoned me now, and he will not be able to continue with us. So we have, if you want to show.
Okay. I have 2 questions for the audience, stimulating question at the end on PGTA, okay?
Sure.
So question 1, what's for you the best method of embryo selection which is associated with the highest implantation rates? Is it morphology criteria on day 3? Is it extended embryo culture on blast transfer? Is it PGTA, or is it time-lapse imaging?
Well, they are all difficult questions. Unfortunately, we don't have a voting system, but then we will rely on your answer. We will.
So I put PGTA because I put implantation rates, and this is very important. It's not live birth rate, and this is embryo selection. Next question. What is the most cost-effective method for embryo selection? Is it morphology criteria day 3, extended embryo culture, PGTA, or time-lapse imaging?
Again, we're looking forward to your answer.
Headache. I have a headache, so we cannot confirm it for sure. PGTA and time-lapse imaging are not cost-effective. We are increasing our cost for maybe little or no benefit. So debate still continues. And when we are dealing with cumulative pregnancy rate, there is no benefit of doing PGTA because your cumulative will be even equal or higher than PGTA patients.
Yes, of course. But Professor Elias, people are going to always argue. They will say, we're not looking for the implantation rate. We are looking for the live birth rate.
Live birth rate, exactly.
Cycle, So
my answer: if you don't have high number of embryos to select, don't do PGTA.
Yes.
For patient to have 1 to 3 embryos, I will tell them, go ahead. Go do your transfer. You will have at least with blast at least 50-60% if you're younger than 35. What's the purpose of doing PGTA? It will be even harmful to do PGTA. This is our opinion.
Okay, let me ask the panel then about the question that Professor Gurgan was going to talk about. What is your opinion about endometrial scratching? Do you think that endometrial scratching improves the implantation rate? And I think I'll ask Dr. Tamer at the beginning to ask Professor Nafa.
Well, I don't think that it should be a blanket treatment for all patients. I think that it would need to be done in a very minority of selected patients that we don't know about. So at the minute, I don't offer it I don't select it as something for recurrent implantation failure patients unless the patient is really keen on it. And I just say this is for future research, and we don't really know which patient would benefit from it.
Professor Tamer, do you do it on the previous luteal phase or early follicular?
When I did it in the luteal phase of the previous cycle, and I think doing it in the follicular phase would have higher miscarriage rate.
Okay, excellent.
Yeah, because
in fact, just to tell you, the recent RBM online guidelines are coming from my colleague, Dr. Sylvestre and Dr. Tayla Sholov. They are both practicing at our university. So we are doing many things for recurrent implantation failure. Then when they publish it, they say that there is no evidence. So I told them we are doing things just with no evidence, unfortunately. And I think, as Professor Tamer said, individualization is the key of success for every single technology we are using.
May I ask you a question? Is it a routine in your practice for recurrent implantation failure to do an endometrial biopsy? Are you doing it in routine or not?
Is this for me, Professor Sonia?
I'm asking all of you, the panel. Are you doing an endometrial biopsy routinely in a patient of recurrent implantation, or you're not doing it?
We don't do it because we don't believe it works. Then there was a meta-analysis. There was a randomized study, big randomized study with Yaqub Khalaf in it and so on. And I think the results came up that there was no change at all. I don't know if people agree with me. Professor Dahdouh, do you do endometrial scratching?
In fact, we don't do endometrial scratching for recurrent implantation failure. We only do it in patients who are going through diagnosis of recurrent pregnancy loss, and if we don't see anything. And this is, again, a very controversial topic, because if we found in the chronic endometritis, we can give it antibiotics, and the level of evidence is very low. We have no single randomized trial showing any benefit.
So yes, there is very little benefit, but in Asian countries, especially in my country, where there is a lot of tuberculosis, and I think even in Egypt there is a lot of tuberculosis. There,
yeah, exactly.
So you do have to look at that aspect as well in these cases, and you do find now people have started. Carlos Simon has started talking about endometritis. Now we are finding this for the last so many years. I mean, and that is why in these patients, when you're doing a luteal phase endometrial biopsy or just premenstrual biopsy, you're actually scratching also. So maybe it is giving a double benefit in those patients, but otherwise I don't practice scratching at all. I don't believe in it. Only thing is, but to rule out endometritis, one should be doing it. And especially now with the microbiome that you have mentioned, with the new area of endometrial microbiome and vaginal microbiome also having to play a major role in recurrent implantation failure, I think it makes sense to do at least one biopsy in all these patients who are coming to us with recurrent implantation failure. There will be more studies, and I'm sure there'll be more evidence.
Yeah.
Earlier, they had actually given up endometrial biopsy. Nobody was doing it, but now it will come back because of endometritis.
Yeah. Doctor Ngada, who is from Namibia, actually, who is asking about the time of doing scratching, if you are doing scratching. So I don't know, Dr. Nafi, if you're doing scratching, when would you do it?
Usually mid-luteal phase of the previous cycle. That's when we did it, yes. Yeah. Ovulation +7.
Yeah. I'll ask Dr. Wafa if there are any questions that you can find. You can unmute yourself.
Yes. There is a question. Someone who is asking you to sum up the content, because he's saying he's totally confused about what is the effective option for a patient with young female with recurrent implantation failure. Could you please just sum up what is the effective intervention that we can use?
I hope there was an easy answer for that.
Yeah.
There is no one effective outcome. And the evidence we have is very controversial. So anything I advise with would be just opinion. As I said, making sure that you have your supplements and your vitamin D, the basic investigations are really important. But other than this, your guess may be as good as mine.
Dr. Sonia, you have any? What do you do for your repeated implantation failure patients?
Actually, just as he's saying, nothing is evidence-based in recurrent implantation failure. And as Elias also said, you have to individualize. Every patient has to be individualized on their own history and criteria. Only then you can, understand and do. But of course, RCOG and NICE guidelines and I think it's RCOG and all, they have all compiled and said some of these are evidence-based. Some of them are not evidence-based. So I think we should stick to that strictly at the moment. Majority of these patients are being put through a lot of immunological testing. The NK cells and all that, especially in my country, everybody has this very big fashion of doing all these things. So that is of no use. So therefore, one has to really select what kind of test you need to do for these people. So
Dr. Sonia, even in US, many, not even in your country, in US, immunologic tests are.
Yes.
Yesterday I had a patient, a colleague and friend in USA. They did through IVF a major battery of tests, immunologic. To be honest, it's useless.
That's what. So,
and but the patient had a low ovarian reserve. She had a poor egg quality. It was about egg donation. It was about even not about recurrent implantation failure.
So again, I have a little bit of a reservation now because see, the corona has taught us a lot of immunology now. COVID is actually telling us that the immune system is actually involved in all the reproductive process very, very intensely. And we do need to look at it a little more carefully because we've never been taught immunology in medical schools. That is the last subject that we always read, we don't talk about it. It's endocrinology all the time. But then endocrinology and immunology go hand in hand. If the hormones are not working, then the immunology is also out of focus. It's not normal. So I think we may learn a little bit more in the coming years about immunology also. But as of today, we have no evidence. So it's like opening a hornet's nest. We can't offer all these tests to the patient without evidence. That is what my take is. I don't do it. I don't. It's
There is another.
I think we have a debate on that question. We all agree.
Yes,
yeah, all right. So one agreement here. The best timing for LH investigation throughout the ICSI cycle.
I have answered that question. I have answered that. Yeah. I have answered that question. I generally do it on the 2nd or 3rd day initially, then on the 6th day, and then at the time of trigger. I don't know what practice is.
That's but maybe the person was not here. And again, a question about. Do you have a question, Dr. Wafa? Is there any question you have?
Yeah. Yes. There is some questions for Professor Elias about the PGD. The first one is that in a center doing so much sex selection, they are asking about the percentage in counseling for the false results. How they counsel? There is any data?
Yeah. In fact, in the paper.
Yeah.
Yeah, Professor Wafa, thank you for the question. In fact, in the paper actually they are reviewing. I look out. One of the reviewers asked me to put up all these error dates by technology. Usually, if you transfer a normal euploid embryo, you can have your clinical error rate. It's between 2 and 5%. The problem is when you have an aneuploid embryo, because usually no one will transfer this embryo. What's your clinical error rate? I can tell you 10, 20%, but this is I'm presuming a number. I don't have any data. No one is transferring an aneuploid embryo unless you do the only thing you can do. It's a non-selection trial. It means you transfer all the embryo, you do the biopsy, and then you look out to your results, the genetic results, after having your clinical result. And this is the only paper recently Richard Scott, it's in press, it's interesting paper for NGS. They had in their paper non-selected selection study, the clinical error rate for if you have a euploid embryo and you transfer, it's around 0 to 1%, and if you have an aneuploid rate, it's around 2 to 5%. This is for aneuploid and euploid. For mosaic embryo, you can have up to 50% error rate, because most of these embryo will give a normal live birth. So when you have mosaic, I think this is the diagnosis, most challenging diagnosis by PGTA nowadays. This is the problem.
Another question was about the rise of progesterone on the day of HCG.
They have asked Hajim.
What do you do? I think it's for the whole panel. So what do you do, Dr. Malik, first?
It depends on the patient. Now, of course, there are studies to say that if it is a poor responder, the level that you look at is different. And if you have a hyper responder, the level is different, you know. So you cannot have that 1.5 nanograms for all the patients. That is not important. That is not what it is. So you have to see what type of patient you are handling and then decide whether you want to transfer or not.
Yeah.
I don't know what the others
What
are.
about Dr. Nafa?
Same. Hello. Yes, same, sir. So 1.5 is the universal, but if it's a high responder, you can be a little bit more lenient. If it's a low responder, then you can tend to be more stringent.
Yeah, and Dr. Dahdoh.
Yeah, I agree with the panel. Most of our high responder having high progesterone level are also, unfortunately or fortunately, OHSS patients. So are freezing for not just progesterone high, we are freezing to prevent OHSS. And in our practice, we have even slightly higher rate, higher pregnancy rate with frozen embryo transfer than fresh embryo transfer. So, and we need to even, and for poor responder, I agree, the levels can be different. But in our experience, we are seeing more progesterone rise with the high responder than the low responder.
That is true. But you know, in the poor responder, that is the biggest problem. Where you have a poor responder, on one side, you need to do a fresh transfer to get better results, you know, because the number of eggs is less. And so a fresh is going to give you a better result as compared to a frozen embryo transfer. But at the same time, the endometrium is out of sync. It is not, you know, the progesterone has risen. So then it becomes very difficult to explain to the patient that, you know, if we are going to freeze also, it may not work. And if you are not going to freeze also, it may not work. So that becomes a little bit of a challenge. But otherwise, yes, in the hyper responder group, it always gives better results if you know.
I have a question for the panel. What do you think about doing progesterone level at the beginning of the cycle? We don't do it, but there is some papers who are doing progesterone level at the beginning of the cycle. If it's high, they give 3 days of antagonist. They wait 2 days, and then they will start again the stimulation. Do you have any experience with that or no?
Yes, I do it.
So what's your cutoff? What's your cutoff on day 2, day 3?
1.5.
Still 1.5. Okay.
Sorry, 0.5. Sorry, not 1.5.
Okay.
Sorry, 0.5.
So do you do it routinely?
I also don't do a frozen embryo transfer. I don't start a cycle if it is more than 0.5.
Okay.
I don't. Also for that.
What do you think, Professor Dr. Nafa?
No, we don't do day 2 progesterone. We just do.
The reason why I'm asking you, I don't know. I know you have a PhD from, I don't know, but it happens that I have a PhD in reproductive biochemistry, and I used to do the hormonal assays myself. And my mentor, Professor William Collins, who is the youngest person to receive a DSc from the University of London, he used to tell me, when you report the progesterone, you have to add the standard deviation. It's plus minus. So if you say it's 1.5, it can be anything from 1.3 to 1.7. And people who are working who do these tests themselves, they are a little bit astonished when we tell them that we take something like 1.5 as a cutoff point. The lady has received treatment for a lot of money, and then suddenly you tell her, well, I'm going to cancel your cycle because it is. And nowadays, of course, we have free zone, but previously people used to cancel it altogether because the progesterone was 1.6 or 1.7. So I don't know. I mean, this is the way I was brought up to see. One can never see the results of the assays of the hormonal assays as you know,
single figure.
Yeah, yes. A single figure. Actually, we used to do the standard curve in triplicates and the sample in duplicates, and it's the coefficient of variation was more than 10%. We would cancel it altogether. So I know in my country there are no laboratories who do the sample in duplicates. They will lose a lot of money. But this is another question. There is a question about endometriosis, deep infertility in endometriosis, and its effect on implantation. Does it affect the implantation, in your opinion, also for the panel? So, Dr. Tamer, do you?
Well, I think any form of endometriosis can affect implantation, and I must say that I've witnessed lots of endometriosis associated with undiagnosed adenomyosis, which revealed itself on MRI. And if you question the patient closely about her symptoms, then you will realize that there is also some myometrial involvement, and these are patients that are dramatically affected. And I use prolonged suppression for that in an attempt to optimize the environment for the embryo.
So what do you do for them?
Suppression, 1 to 3 months, long-acting agonist.
Yeah, so you're coming to our meta-analysis, our Cochrane review, because you know, Sonia, we have a Cochrane review on giving GnRH for 3 months before IVF in patients with endometriosis in general. I mean, it was published 2006, and this year there was an update on it. I don't know if you do the same, Sonia and Professor Elias.
It still holds true. It still is the best protocol for endometriosis to do an extra long down regulation and then stimulate. It still is the best. But of course, with the coming in of AMH into the scenario, things have changed a little, because basically many of these patients have a very poor AMH, and then you don't know whether you should be down regulating them so much or not, because again the AMH is going to crash once you down regulate them. So that it becomes a little bit of a challenge at times, but the long protocol is the best.
I would just probably clarify. I do the suppression before the embryo transfer, not before the egg collection. So
for frozen embryo transfer?
Yes, before the frozen embryo transfer. So I just secure my eggs without suppression, and then I do the down regulation for the endometrial factor.
In fact, we'll be looking forward to see the new Cochrane, because the last Cochrane review on Depo-Lupron before the IVF was only on 3 studies. Numbers were very small, and it was just only the long protocol. This is not the actual practice. This is now we are doing antagonists, so we don't know the answer if we give. There is, I think, one of the Ziegler studies ongoing, with comparing OCPs with placebo 3 to 6 months before antagonist, to see if there is any benefit for endometriosis patient. So I think it's an ongoing trial now.
Yeah, Dominique de Ziegler, he did the study, but it was not fully randomized. I think it was kind of quasi-randomized. And the new Cochrane actually involves only 4 studies. They're not many. And in fact, to be fair, the live birth rate was not improved, in fact, by including this 4th study. So
is there any antagonist study, Professor Hassan?
No antagonist. No antagonist. So we were waiting, of course, for some randomized studies on antagonist protocols.
So to see what's the best priming or best treatment before endometriosis. Usually we don't do anything. We start the stimulation. This is in our practice. This is McGill practice also. We had the panel last year. So in at least in Montreal, we are not doing any down-regulated unless the patient is has severe pain and she wants to go for IVF. We'll suppress her with 3 months or 6 months before.
Yeah, I think what Dr. Nafa is doing is something very, very clever also. So just to secure the embryos and then put them whenever you're ready. Yeah.
This is we call it. Yeah.
I think we are
sometimes we do stimulation, we do surgery, and then we transfer.
Yes. Same here.
Yes, sir. The discussion is going beautifully, but I know that it's 2 o'clock already in the morning for Sonia. So I'm going to ask Dr. Wafa if there is any more questions from your side.
I think most of the questions have been asked. There is one question about the BGT for Professor Elias as well about
the last one then. Yeah.
Yes, this will be the last one. It's if there is any balanced translocation or monosomy 15 or 16 or something, can we go for embryo transfer or not?
if you don't have any euploid embryo,
Yeah.
if this is the only available embryo, I think
Yes,
the
it's
patient should have, the patient should have a complete genetic counseling before any transfer to explain the outcome, to explain what are the risks and what is the expected workup during pregnancy for any established pregnancy.
And
This
then
is the way to do it.
And then have amniocentesis also.
For sure, yeah, for sure. And even after that, maybe postnatal, but we don't have enough data on that. This is the problem.
Yes, yes.
And even the ASRM last clinical bulletin on that, they mentioned clearly that there is even the classification of mosaic embryo is not evidence-based. It's just only about the International Society of PGD, and this is only by just opinion classification. It's not evidence-based.
Yes, yes, sir. Yeah, with this, I think we come to the end of this webinar. I want to take this opportunity to thank our international speakers for giving their time and share with us their vast experience and great knowledge. Professor Elias Dahdoua from Université de Montréal in Canada, Dr. Sonia Malik from South End IVF Center from in New Delhi in India, and Professor Tamer Nafa from Manchester. And I would like to thank my co-moderator, Dr. Wafa Benjamin, for being with us today with her continuous help. She is the dynamo of our Egyptian Representative Committee of Doral College. And thank Merck for their support. And now we will split ourselves into two between the 3rd and the 5th of December, either to be with the Indian Society for Reproductive Medicine or the Middle East Fertility Society, in order to see Professor Dahdoua and Dr. Sonia and others. Hopefully,
we're looking forward. Thank you very much for putting up this excellent webinar.
Thank you very much, Elias and Sonia. And
thank you, everyone. Enjoy that.
Say in French, à la prochaine.
À la prochaine.
À la prochaine, alors.
I shall send you the photos. Good night.
Thank you.
Bye.
Thank you very much. And booster bees, of course. For the Bye-bye.
Bye-bye. See you soon. Bye-bye.
Soon.